We all ready? All right. And I'd like to welcome everyone and officially call this meeting to order. Beautiful May 1st. I think we have a quorum. We're all set. So first, we have the minutes of the last meeting. Are there motions to approve? Are there any additions or corrections? If not, all in favor? Opposed? Abstentions? Okay. Certainly we'll listen to a few of you. Okay. So we have a number of items more in the form of bringing us up to speed on a number of major activities that staff and also looking back over the big issue with respect to the merger of Beth Israel, Deaconess and Great. So I'm going to turn this over to David, and you're going to take it away.
Great. Thank you, Chair Altman, commissioners, and members of the public. Thank you for being here today. Happy May. As you said, Mr. Chair, today's meeting, we don't have any official votes scheduled for today's meeting. This really is an opportunity to have some updates on some of the work that the staff has been up to, but also a great opportunity for some discussion and some input and feedback from this board, specifically a little bit later on in the meeting when we're going to talk about some of the research projects that the staff has been working on so far this year, or plans to work on this year, and really want to get your guidance at this stage on some of the different research projects we're working on. So hopefully we'll spend some time and have a good discussion at that portion of the meeting. Do want to recognize first a new face here at the board, Brian Kopacki. Thank you for being here. This is the new designee for Secretary Heffernan at the Administration and Finance. Our former designee, Elizabeth Deniston, we're very proud to give an update that she has moved on and is working for the Governor's Legal Counsel, working for the Governor. So give her a hearty congratulations in her career move. Excited to have you with us here today. So to kick off today's meeting, we're going to start with some of our market oversight updates. And so I'm going to turn it right over to the Deputy Director for our market oversight team, Megan Wolf, to walk through some material change notices, and then spend a little bit of time talking about returning to Beth Israel Leahy, and to give a briefing on what happened after we issued our final report, and some of the updates since then from both the Department of Public Health and the Attorney General's Office. So with that, I'll turn it over to Megan.
Thank you, David. So this is probably very familiar to you now. Since 2013, the HPC has received notice of 99 provider transactions, so close to 100, with clinical affiliations the most frequent, followed by hospital and physician affiliations.
Can I just stop you there? I want to add 100 too. No, we've at various points spoken about doing a retrospective look at those of these for which it would be possible to do so, to see how the outcomes compare to what's suggested to us would be the outcomes. And I see you nodding because it's obviously been a year.
It's actually on today's agenda. So we will be talking about our market retrospective project maybe 2/3 of the way through the.
Mr. Chairman, I take back my comment.
The HPC has one notice currently under review, a proposed partnership for joint contracting between Emerson Hospital, Carrington Healthcare System, Haywood Healthcare, Holyoke Medical Center, Signature Healthcare, South Shore Health System, and Sturdy Memorial Hospital. These organizations are currently part of the Massachusetts Value Alliance, which was formed in 2016 to facilitate cost savings for its members, primarily through group purchasing and shared service arrangements. The formation of this group did not trigger an MCN review because there was no joint contracting or clinical affiliation at the time. Under the proposed transaction, the Mass Value Alliance is planning to engage in population health management and risk-based payer contracting on behalf of its members. Berkshire Health Systems, Lawrence General Hospital, and South Coast Health System also participate in the Mass Value Alliance, but are not parties to the transaction because they are not planning to participate in the payer contracting initiatives. Since the last board meeting, we elected not to proceed to a CMIR for two transactions. First, the proposed acquisition of New England Geriatrics by Health Drive Corporation. New England Geriatrics provides mental health services to patients in geriatric psychiatric hospital units and nursing facilities in Massachusetts and Connecticut, and outpatient mental health services in West Springfield. Health Drive provides business, management, and administrative services to long-term care, skilled nursing, and assisted living facilities in 11 states, including Massachusetts. For this transaction, our review suggested limited scope for spending increases, and we did not review evidence that the transaction is likely to negatively impact clinical quality. With respect to access, Health Drive has stated that it serves all patients, including MassHealth patients, in a non-discriminatory manner without regard to their insurance status, and that it plans to continue this approach at this time. Second, a proposed joint venture between Bay State Medical Center and Beach Health Development. The parties propose to operate a new psychiatric hospital in Western Massachusetts and close inpatient psychiatric units at Bay State's community hospitals. The parties propose that the new facility would have about 30% more beds than the current Bay State system. They will need to seek licensure from the Department of Mental Health, and likely the closure will trigger the DPH Essential Services closure review process as well. For this transaction, our review suggested limited scope for spending increases, and we did not review evidence suggesting negative impacts on quality or access.
Can I just ask a question? With those beds being closed, is it within our purview, or do we ever ask about what the use of that space is going to be, how it might impact patient care?
It is within our purview, and it was not something we reviewed in this case.
So just, there's a lot of negatives in this sentence, so I'm trying to figure it out. We did not review indicating that transition is likely negative. I'm sorry. I shut it off on purpose. As I said, there are a lot of negatives in this sentence, so explain to me what that sentence said.
We don't have any concerns about the transaction with regard to quality or access.
All right, so that indicated that we did look.
We looked, but we did not find any evidence that would concern us.
Yeah, I got it.
We're lawyers on this team, so I'm sorry for all the double negatives.
Because, I mean, it read in the beginning, and I'm, that, well, we didn't look at it to not find any negatives, so I was, but the answer is we did look at it, and to the extent that we looked at it, we could find no negative.
That's correct.
On the first one, the New England Geriatrics by Health Drive, given all that we've read in the news about some of the national nursing home operators, did we do any due diligence on Health Drive as a corporation and their ability to take on this role?
So Health Drive will not be operating the nursing homes themselves. They contract on behalf of providers who go into nursing homes.
So it's a management service.
That's right.
It's a management service, and they provide podiatry, optometry, dental services to the residents of these nursing homes. And with the acquisition of New England Geriatrics, we'll be able to add behavioral health as one of their service offerings. I would note that we did contact skilled nursing facilities that have experience with Health Drive to try to understand what their experience has been like, as well as review their past history and operations in Massachusetts.
Thinking on the site one, so the net number of site beds goes up.
That's correct.
Do we have any evidence of a need for more site beds, that there's unmet need in that area?
can't speak to that specifically.
I mean, the parties themselves absolutely feel that this will enable them to more timely place patients in the psychiatric facilities than at their current capacity today. And I think there is some evidence that there are people who have been waiting for psychiatric placement, so the additional capacity, at least as the party stated to us, would help alleviate some of that need in the area. I would note specifically on the psychiatric hospital piece, and to a previous question, the timeline here is about 2 years from now that they'll be opening, that they'll actually be closing the beds at these community hospitals and opening the new facility. So there are still some unanswered questions of what exactly those beds will be licensed as, what may the access space be used for. Some of those questions may be answered at that time when it goes through a Department of Public Health Essential Services review.
And then specifically, the parties don't currently have any licensed adolescent psych beds, and so it's possible, I don't think decisions have been made, that this would provide access in Western Mass where there isn't any right now, and they, where patients may have to come to Eastern Massachusetts at present.
I mean, I'm quite willing to believe there's a gap in need, but we also have strong evidence in healthcare research that supply drives demand, and just good to remain skeptical.
When does the DPH process start? I know you said it's a 2-year timeline for the closure, but when would DPH start reviewing it to answer some of these questions that we've raised?
We can get back to you on that.
Yeah, there's a time period before they can close that. I don't know.
Hearing no other questions. So as you all know, the HPC completed its cost and market impact review of the Beth Israel Lahey Health merger in September 2018. Our key findings were that the proposed merger would enhance the parties' bargaining leverage with payers, enabling it to significantly increase its prices, that the parties' proposed care delivery programs and plans to shift care to Beth Israel Lahey Health from other providers and to lower cost settings within the Beth Israel Lahey Health system could result in some savings, though not enough to offset the projected price increases, and that the BILH-owned hospitals generally had a low mix of Mass Health patients, as well as that Beth Israel Lahey Health is an important provider of behavioral health services. The HPC's final CMIR report included a referral to the Attorney General and a recommendation to the Commissioner of Public Health that the department reconsider its approval with conditions of the party's DON application. At the board's request, HPC staff will summarize the conditions of approval imposed by the DON program and the Attorney General's office in October and November 2018, respectively, under which the merger was allowed to go forward. I'd like to caveat that this is the HPC's understanding, and I am not speaking on behalf of the DON program or the Attorney General's office. The DON conditions of approval are detailed in the decision letter issued by the DON program on October 10, 2018. The conditions apply for 10 years and can generally be categorized into 3 buckets. Requirements for ongoing reporting by BILH on measures of costs, quality, and access to care, conditions related to BILH's spending growth, and conditions designed to ensure access for Mass Health members. As you can see here, the DON conditions require extensive annual reporting by BILH on a broad range of information, including its payer mix and participation in payer networks. BILH is required to report on measures related to improvements in care delivery and access, as well as to provide updates on the integration of patient data across its system. BILH must quantify internal operational savings from the merger and detail how much of those savings have been used to improve access to care, especially in primary care and behavioral health services. BILH must also report on its efforts to reduce community-appropriate care going to its AMC. BILH must report to the DON program whether any of its entities have been referred by CHIA to the HPC through the performance improvement plans process that year. If so, and if the weighted average TME growth for all BILH entities across all payers exceeds the benchmark, BILH would be required to work with DPH to develop a plan to invest a portion of the above benchmark spending in its behavioral health and primary care services and its community providers to improve access to needed services. In addition, if BILH is required by the HPC to conduct a performance improvement plan, non-compliance with the PIP process could jeopardize its DON status. BILH must submit a plan to DPH within 6 months to address its low mass health payer mix. It must use good faith efforts to ensure that its mass health mix, both overall and for each of its component entities, does not decrease. If it does materially decrease, BILH is required to work with DPH to develop an action plan. BILH's contracting affiliates and DISH hospitals, disproportionate share hospitals, which already have higher mass health payer mix, are not subject to this requirement. BILH must also develop a plan by which, within 2 years, all of its employed providers have applied to participate in mass health. In addition, BILH must make reasonable efforts to inform the public about any service or other changes that are likely to impact local communities. Finally, if the HPC hasn't otherwise conducted a CMIR of BILH within 5 years, DPH will request that the HPC conduct a CMIR, and BILH must cooperate with such a review. DPH would use the CMIR findings to assess BILH's compliance with the DON conditions. Compliance is enforced through the DON regulations. If DPH finds that BILH has failed to demonstrate compliance with the DON conditions, it may require BILH to contribute up to 5% of the DON project's total value to fund public health priorities.
Let me just stop you here. And go back to the comment that David raised before, because the way I read this is that it's put into, yeah, I had it on. The reason I bring it up is that this puts into the direct language this retrospective that indirectly you were talking about. In other words, as I understand it, we have, along with the DPH and the Attorney General, are very concerned that in fact the parties do what they say they're going to do, and that we play a role in several different ways, whether it's through the PIP process, right? I mean, or other, to sort of look back and see, okay, what's happening with respect to price increases? What's happening with respect to coverage and so on? Is that a fair assessment?
That's very fair.
And, you know, and when we begin to, you know, the others we sort of let pass with the idea, well, occasionally we may want to look back, but this is a good template, I think.
Yeah, you know, as we talked earlier, I think I'd like to suggest that we do some look-backs now on other situations that we've approved. Maybe the staff could suggest to us which, looking back over the past 4 or 5 years, what we approved with implied or explicit conditions, and could we audit or take a look at whether those conditions have been met? Even a couple of cases would, it'll also make us better at doing this one when we finally get around to it.
Absolutely. I wanted to also give Undersecretary Peters the opportunity to add anything if she wants.
I get a question on the, what sounds like a mandate for providers to participate in mass health. Is that the first time that DPH has done that? It's really the second part question is there risk there that employed physicians bounce out of the hospital because the hospital can't afford Medicaid reimbursement rates?
So I believe it's the first express requirement, but there have been prior transactions of HPC that looked at the payer mix involved in a given transaction. So reporting and ensuring that the level of healthcare
they're using the word employed, so if you're a non-employed group that's affiliated, they don't have quite the leverage. So it's not so much all the providers.
That assumes that they stay employed through their lifetimes, and those are contracts as well. So it's not, there are certainly markets where physicians are bouncing out of hospital agreements for.
No, but I'm just saying that we need to, the word employed is important, because Beth Israel and Lady, I'm sure, have affiliated positions and related activities that are not employed. So I gather the word employed is an important component of this.
That's right, and I would say that that's the number of physicians affiliated with the system is certainly something that we would expect to track over time.
Affiliated and employed, that mix, we track.
So do we know which physician groups this would not be applicable to? Because if you say they're employed versus affiliated, so we're saying the affiliated physicians are not obligated to petition to participate in Mass Health?
That's correct. A number of the large groups that would be part of this new contracting network have both employed and affiliated physicians in different proportions. Can certainly walk through that with you if you'd like. I know that traditionally the Northeast physicians were primarily affiliated and not employed. I don't know what the current status is.
But I would add, even beyond this particular provision, there's a broader provision around increasing the mix of Mass Health that could include strategies around making sure that the contracted physicians are also accepting Mass Health. But the explicit requirement here is limited to the employed physicians, as that's the place where they have the most control over the physicians. Great.
In addition to the DON conditions, the BILH merger is also subject to conditions pursuant to an agreement reached between BILH and the Attorney General's office. That agreement limits system-wide price increases for BILH for 7 years to 0.1 of a percentage point below the cost growth benchmark. Currently, that's 3%. The cap cannot go lower than 3%, even if the benchmark is set lower in future years, but it can go up if the benchmark rises. The cap does not apply to Lawrence General or Cambridge Health Alliance. These price growth limitations apply both to fee-for-service contracts and to many alternative payment method contracts.
Megan, can I just interrupt with you? This is only a meaning to ask. The carve out for Lawrence General and Cambridge, is that a complete carve out, or does it mean they can go above the cap, but that has to be calculated back into the total entity?
I believe it's a complete carve-out. Their price increases would not count as part of the total system-wide BILH increase subject to the cap.
But they're not technically part of the group. They're in this kind of never-know land.
They contract as part of BILH, but they are not
always done
owned.
that. Yeah, that's right. And they're not technically part of this combined group as an own entity.
Not as an owned entity, correct.
So this is a complicated and an important part of in the sense that we're dealing with price, not total spending. We have to understand that, because that's easier to sort of monitor in a way, but it also leaves the volume side of the equation.
Except the APM part is the total spending. So it's an interesting mix between our price on the fee-for-service side and total spending on the APM side.
So currently, for the APM contracts, it would only be prices negotiated for specific services underneath an APM contract that would be subject to the cap.
So it's not the total.
It's not the total global budget, for example.
I see.
But when we look at the PIP, we do look at total. So, and remember, this doesn't preclude any of the activities that we're currently engaged in. So if we see some rather anomalous situations developing with total medical expenditures growing quite rapidly, even though technically we can still
correct. So the PIPS process and the review by the HG and HPC continues, and in fact is actually strengthened by some of the provisions in the Department of Public Health DON agreement, where if spending does go over the benchmark across a lot of payers, they may be required to make an investment back into primary care or behavioral health care, and as well as if they're non-compliant with the PIPS process, that could endanger their DON approval. So both of the DPH conditions do strengthen the PIPS process in our review there, but I think important to recognize that the PIPS process, as it currently stands, is a retrospective review, and it does take there is a data lag that occurs there. So we won't see some of that potential spending increases until a year and a half or 2 years after, but the price caps will happen in real time.
No, but let's play this one out. And that several years from now, the price cap is 2.5%. To pick a number, totally because we now have new authority. This says that with respect to this, it can't go below 4 rates, but it doesn't preclude us from within our PIP to continue the process within the authority that we have.
So we could reduce the benchmark below the current, at a certain point in time, we could reduce the benchmark, but the price cap cannot go below 3%.
Well,
For this agreement, correct.
again, this is the hypothetical that this agreement does not preclude us from continuing to function as we are now. To some extent, it strengthens it, but to some extent, it's separate. Fair? Right? Counselor?
Yes, I was just to underline that nothing in this agreement sort of supplants our existing authority to do a performance improvement.
Including to require this 3% floor does not apply to us. We could create a lower floor.
On the benchmark.
And the other thing, Stuart, in terms of putting this out, is the Cambridge-Lawrence situation, because again, they're now given within the Attorney General's agreement a kind of a license to raise prices higher than the rest of the system.
I don't think so.
It does, the cap does not apply.
I know, but it doesn't change anything with respect to that. It doesn't give them a license to do anything more than they could do.
Well, there are two authorities involved, the AG's office and the agreement.
But then there's ours.
There's us. I'm just clarifying that for the record.
What I'm trying to say, and correct me if I'm wrong, is that nothing in this agreement changes our authority. Currently, Lawrence General, just like every other provider, to the extent that they exceed the benchmark in a systematic way that brings them before us through the CHIA process, we can then question what's going on. So, and that would not change. So they don't have a license to do any more than they have today. So it's not like we've given them a license to raise prices that before they wouldn't. It just doesn't stop them from doing what they could. Is that a fair assessment?
I think that's correct. So in the hypothetical, just to be clear, the Attorney General's agreement with the ILH does not hold Cambridge and Lawrence General to the price cap. The HPC can still hold provider organizations to the TME benchmark under the PIPS process.
There is a policy side to this, Stuart, that I'm just noticing, which the reason the AG probably included this agreement is that they believe that Cambridge and Lawrence need more financial support, or at least shouldn't be restricted to the same level the combined entities do. We don't have to agree with that, but we should notice that that's the policy. There's a policy goal embedded in it.
Well, I don't know. I mean, none of us, not only I, none of us were party to those negotiations. And we do know that these two organizations were not completely happy with the idea that they were not included in the totality of it. So you could make an opposite argument and say, well, since they weren't part of the whole process, why should they be constrained?
Let me chime in on the math question. It's still perplexing to me. If 5 years out, $10 billion revenue system is capped at 3 and has 30 million in revenue. And yet we have a PIP of 2 or 1.5. What happens to that $15 million? Does BILH have the right to say, doesn't matter what the health policy commission says? They do not.
Hey, listen, I don't wanna,
Well, Stuart, let me make one other point. I mean, the math is a little confounding, but to Don's point about a policy, there are policy goals to reduce spending, right? And putting a floor is seems a little antithetical to the purpose of what we all do. An example of a policy conflict is CMS announced 8 days ago that they're going to have a 50% spiff for primary care payments in order to reduce overall costs. So it starts to get confounding any kind of price control, but certainly a floor seems to me to be a risk of potential conflict.
so, again, you guys can jump in here. I sort of read this a little differently. In the following sense, and that's why I made the point. There's nothing in this agreement. So here's the 3 parts that I see for the sake of the discussion. As Megan pointed out, the combination of these 2 large entities does give them the potential to have market leverage, which they don't now have. So we raise legitimate, I think, concerns that this potential could generate substantially higher reimbursement than they would have gotten before the merger. Now, these institutions, for the most part, have not been overly above, if not they've been below the benchmark for the most part. So it's not like we've taken very high price organizations. They're not poor, but they haven't been at the top of the list. So this agreement that was agreed to by the Attorney General and the parties said, okay, we're concerned about that, and we're going to try to limit you to be consistent with the price part of the benchmark as of today. And that's what they did. So they said, okay, now, again, I don't have anything to do with this. To the extent that which was, one part was surprising, I think you brought it up, it says that if the benchmark were to change and go lower, you can't superimpose a lower number into this agreement. But if it goes higher, you can. Again, we might have some difference of opinion, but during negotiation. But the point I keep making is that to the extent that the benchmark gets lower, and we don't lose our authority to say, hey, this does not preclude us from questioning your behavior consistent with the benchmark in effect in that year. So it doesn't give them a license to ignore what our process is as of today, or unless somebody took that process away. So I'm saying it doesn't. If he hasn't, I might have written it differently, but it was part of the negotiation. But the thing I was concerned about is that if it says, oh, by the way, the Health Policy Commission can no longer use its leverage, then I would have been even more.
And Commissioner Kreider, I just want to clarify something that I think might have been confusing. The price cap is always a ceiling, but the ceiling cannot drop below 3%. So it isn't a guaranteed price increase for the parties of 3%.
It's not guaranteed, but it is probably gonna happen.
But I wouldn't call it a floor.
One policy thing, Stuart, you mentioned the other community hospitals, Lawrence General and Cambridge, and we in our report had identified those institutions as being really important providers of services for non-white populations, for the Medicaid population, and had raised some questions and concerns about how they would fit in with this new system moving forward. And as Megan will continue to walk through, the Attorney General's office, I think, also had some concerns about access for these important institutions and wrote in provisions that do provide financial assistance, require financial assistance directly to those institutions. So there was, I think, a policy imperative there around protecting and strengthening those important community providers, even if they're not part of the corporate-owned system. And that's part of a major theme in the Attorney General's requirements.
Before I move to that, on the next slide.
Hold on a second.
Sure.
I don't want to prolong this too much, but what this is, I think this could come back to us in future. When the CHIA refers cases to us to consider for PIPs, and the staff produce the reports on whether the rates of rise of total spend has exceeded the benchmark. Lots of things are taken into consideration, but one of them is not what David just said. I don't remember a review that says, gee, this organization is so essential and they're having a lot of financial problems right now, so they need to be given special permission to exceed the benchmark on policy grounds. We haven't done that, right?
No, we don't, and we don't have the authority to do it.
We don't?
It's not though in our discussion.
I would add, there have been occasions in our regulations and in our process, we do look at the financial strength of the institution. We do have what their relative price is. So if it is a low price provider in the market and they exceeded the benchmark due to the fact that they were able to negotiate higher commercial prices, we may consider that very differently if it's a low price provider moving up a little bit than a high price provider who is maybe separating themselves even further from the back. So that type of context does, I think, play into our decision around it.
I remember at least a couple of occasions where, upon inquiry with payers, they told us that yes, those particular contracts went up rapidly because we decided that that hospital was not being paid appropriately, and we in essence took it out of everywhere else. So that was part of what we thought was our sort of overhead that we could throw there.
So there is also a price growth limit for Medicare Advantage plans, that the percent over Medicare paid to BILH cannot increase. BILH can petition the AGO to revise the price growth limit under certain circumstances, including a change in law that increases the cost of care. Under Mass Health requirements, BILH providers that accept Mass Health must continue to do so, and BILH must make good faith efforts to have all of its employed providers apply to be Mass Health providers within 3 years. BILH must also conduct a marketing campaign targeted to attract Mass Health patients with specific outreach around New England Baptist. The agreement.
I do think, in reference to your comment, this provision here about the whole system itself being much more focused on Mass Health, I think is really a key part of this, right? I mean, as opposed to the individual providers. I mean, the idea that for whatever reason, the Baptist, for example, has just not been a major player in it. And there were times when some of their organizations wouldn't even contract with Mass Health. I think this provision here is really aimed at getting all of their pieces.
The agreement also, as David mentioned earlier, mandates support for and investments in community health centers and safety net hospitals affiliated with BILH. BILH is required to make good faith efforts to maintain its current affiliations, and it must negotiate price increases for Lawrence General, CHA, and any BILH-owned hospitals with lower commercial prices that are at least as high as the average price increase for BILH overall. The agreement limits the extent to which BILH can recruit physicians from safety net hospitals and community health centers, including BILH affiliates and others. BILH must continue its current level of financial support for its CHC and safety net hospital affiliates for 8 years, and additionally contribute $8.8 million over that time. BILH must also make contributions to expand access for communities of color and low-income communities of at least $5 million, as well as to improve access to behavioral health services, investing at least $16.9 million. Finally, the agreement requires reporting and monitoring for 10 years. BILH must provide data and analyses to the AGO annually. Some of these data are designated a public record, and some are confidential, but the agreement provides that the AGO may share it all with the HPC. The public information includes analyses detailing BILH's targeted cost savings achieved, and total savings achieved in relation to targets, and information on elimination or creation of clinical services or consolidation of operations. The confidential information includes, for example, information on volume, payer mix, service mix, and patient origin for each BILH facility, and a list of physicians who became employed by or began contracting jointly with BILH in the prior year. The agreement provides for third-party monitoring for 10 years. The monitor will produce an annual report assessing BILH's compliance each year. If BILH complies with the agreement for 5 years, it may petition the AGO to amend its obligations. Yes.
So a couple of questions. One is, are the price data that we were just talking about on the previous page, are those in the public data or the private data? Second question is, if they're private, has the Attorney General agreed to share those with us, or if the Attorney General just has the right to? And then third is, have they named the monitor yet?
I'm going to take those.
I'll take the third one, and then we can jump back to the other. So we do understand that a third-party monitor has been agreed to by the parties in the Attorney General's office, and we did talk to the Attorney General's office, and they authorized us to make that public today. So that third-party monitor is a firm called Grant Thornton. It's a national financial consulting firm and accounting firm. They do have, as I Googled today, some offices in Boston. But that is our understanding will be the agreed upon third-party monitor, Grant.
And on your other question, as far as I'm aware, and we can also get back to you with more detail if you want, the pricing information will be provided to the third-party monitor to assess BILH's compliance with the price increase limit. So that I'm sure that wouldn't be publicly reported outside that. Whether for the public reporting and the confidential reporting, the AGO has the authority to provide it to us, but I don't believe the agreement says that it will. I assume that they put us in there for a reason.
So we would help if we cleared, it might help if we cleared some of that up with the AGO. So that, because we may want to use it as we're examining the system over the next couple of years.
Absolutely. And the third-party monitor's annual report is a public record, but the underlying data and analyses to produce that report a little bit less clear.
And I would assure the commissioners that, both for the Department of Public Health and the information that they're going to be collecting, and for the Attorney General's office, we will be in close communication and coordination with them about what access to data we will have. None of that has been confirmed or decided today, but will really be kind of the next phase of work with those agencies. And I even level of collaboration and cooperation and communication with those agencies has been outstanding thus far. So we'll keep you posted on that.
And just clearly that's really important, because as I'm looking back, we talked about the retrospective look and how important that's gonna be, and what's our role and what information we have and how can we analyze it and share it in certain ways. Just looking at this, how I read this is that our role is really, if they get reported or referred to CHIA, that's one way in which we're gonna have some oversight and get information to look at and review. And the other was if they don't do if we don't call for a CMIR, that it triggers automatically in 5 years. And so there's the potential that if they don't get referred to CHIA and we don't, within the 5-year window, and we don't have good sharing of information with the Attorney General, the DPH, and we'll have limited ability to monitor and review this and meet our obligations, I think, as intended.
Agreed, and I don't have any reason at this point to think that those information sharing won't be meet our needs. And would also add, we do, I think, given your guidance, would expect that there will be some annual work that we will do, that we will not just walk away from this transaction and come back to it 5 years from now, when there may be that potential of the required CMIR. And there are other opportunities that we have, including the cost trends hearings, to keep track of the transaction.
And if we are told to do a CMIR in 5 years, we have the ability to mandate information from the parties and other stakeholders.
Megan, on the restrictions against recruiting certain physicians, do you know any more about the language that's in the agreement? I mean, how would that apply to Dr. Foley and not apply to Dr. Kreider?
That's great.
So for 1 year, BILH must not hire any primary care provider who is currently employed by or contracting with a safety net hospital or community health center. And then for 8 years, BILH must not try to recruit most or all of the medical staff in a department of a safety net hospital.
So that seems a little dicey from the standpoint of the employed physician, in terms of restricting that individual's freedom to contract. I don't know, Stuart, I'm too new at this to understand, but are there enough questions here that we ought to ask the AGO to come in and be part of the hearing where we can ask questions and get answers?
Sure. My sense is probably, I wouldn't say it's above our pay grade, but I think a lot of these could wind up in the courts.
Yeah. What I'm saying, to avoid conflict between the HPC.
But I don't think it has anything, and we can stick our fingers into a lot of things, but in and of itself, I think you hit upon an issue, which is to what extent this invades somebody's ability to function there, which in and of itself doesn't, I mean, it may impact on what we do, but I would think it's going to hit a lot of other problems if it's a problem. In other words, if I think you raised, as you brought it up, I agree with you. I'm not sure it would affect what we do that much, but it could affect, as I said, a legal decision on the part of the individual.
We look at clinical affiliations all the time. And how many in the 99 were medical groups?
Rarely,
23. So.
But not like that. I mean, we have a major responsibility, and I don't want to minimize it, but our responsibility is an overall responsibility to be concerned about costs, to keep spending in line with the benchmark, if not lower, to make sure overall there's good access, and that quality is maintained, if not enhanced. We try not to get into the middle of the functioning of individual organizations or relationships between individual providers and some of that. Lois, you may want to.
I guess I'd just say on these particular provisions of the agreement, I mean, these were negotiated by the parties, by the Attorney General's office and BILH on willingly and voluntarily, and they came to these terms, and it's certainly not my ability to sort of second guess the propriety of doing so, and as we've noted in this discussion, if the Attorney General had certain policy reasons on behalf of other safety net providers and community health centers, and perhaps there were sort of an issue with a desire to maintain primary care providers in those settings. So I guess those terms were reached, and presumably with good reason.
And to add to that, I think we are being very reticent here in interpreting this agreement. We don't think that that is necessarily our role. That being said, Commissioner, to the extent that there are unanswered questions among commissioners, we are happy to engage with the Attorney General's office to think about what is the best way to get that clarifying information to you and to others. And I think they will be open to those types of conversations.
Don?
I would, on a different point before we close this item, so I don't want to interrupt this conversation, but yeah, so I want to take us back for a moment. And please, if you're really out of order, I wouldn't be upset. Well, I will be, but I won't say anything. To David's point, with which I have strong agreement about the look back, I think the look back, the idea that we're establishing here a principle, which is we're looking at what the conditions are, and we, the commission, will look back at some point on our own initiative as to compliance. I think it's a very important idea. I think it's relevant to our future effectiveness. As I said earlier, I have an opinion. I'd like to make a rather formal suggestion. We should do some look backs now this year, if the staffer can do it. And to me, and I was thinking of how we would do that. And what I would recommend is that for our next meeting, July 24th meeting, if the staff could come back and designate to the commission 3 or 4 or 5 prior decisions. They would have, I think of 3 properties I'd be listening to. One is that it's a consequential decision, not a trivial one, that we approved or did not refer, relatively sizable issue. Second, that it's ripe, that there's been enough time passed that we could actually see whether whatever was represented was followed through on. And the third condition, there are explicit agreements or explicit representations in the parties' application, parties' representations to us about, say, price increases or Medicaid coverage or whatever we've regarded as. So if you can say, okay, we were able to find 4 such cases that are now ripe, explicit, and consequential, and then the question would be, okay, what would a look back look like to see did it really happen or not? And then sometime in the next 6 months or year, we'd actually then have a booked item in our agenda. My consider request is that if it's not out of order, that the staff on July 24th designate those reviewable situations. Is that clear?
Don, let me ask this more in the form of a question, or if not a comment. Listen, I'm all in favor of look backs, but I do think we have to be careful, and I'm just throwing this out. To the extent that a group comes before us and we choose, and they don't make any assertions about what they're going to do, they want to merge, and our staff, for whatever reason, based on assessments, doesn't look like a big deal, and we pass it by. I don't think we, and then it turns out that that merger does generate some things that, had we known, we'd have been a little more concerned about. I think we need to be careful there. That's different when then, which is where you also mentioned, where the parties say, and we won't do this, don't worry about it, don't worry about this, and in fact, we look back and finally do. I think that those are different situations.
Totally agree, and that's why one of my conditions would be a reviewable representation.
Exactly, so I think we're on the same wavelength. And there are not a lot of those, because when I think back over the 8 years that we've been doing this, there have been some big issues we had to deal with, but there have been a lot, as Megan pointed out, areas just chose not to, they didn't seem big enough, they didn't seem like it. And I think for the most part, it's gonna be hard, if not impossible, and maybe the one of them that makes some sense, as opposed to those that were big where we made concerns where things happen. So I think at the end of the day, there's gonna be a limited number of areas that we definitely would be looking at. We'll have to see. But in principle, I think to the extent that we did raise concerns, the parties came back and said, don't worry about it. I think we have every legitimate right to look back and say, well, okay, we wanna learn. It isn't so much that we can slap their hands as to say, well, okay, now we've learned something and then in the future we're gonna be, so there are two ways of using this look.
The other thing I'm interested in, the two bullies point is, can we do it if we decide to? Can we get the data available to us? And we assume that we'll be transparency, I don't know. We'll know till we try.
So, just to put a bow on this conversation, very pleased to report that that is very much our plan for this year. We'll talk a little bit more about what we're thinking in terms of both a retrospective analysis of how the entire healthcare market has changed in Massachusetts over the last 7 years, as well as looking at specific transactions, as you say. And we do know of specific transactions in the past that we have either reviewed or let go through where there were explicit rationales or goals of those transactions, moving more care back out to the community hospital as opposed to the academic medical center, commitments around improving Medicaid payer mix that were explicit. And so there are these levels of questions, both in things that they, positive things that they aim to do with the transaction that we can test, as well as were there inappropriate price increases or spending increases that we saw after the fact. And so we do have that as part of our agenda this year. And I think, as you said, I think it's really important for us to continue to build that analytic strength and the recipe for how we do this so that we can continue to improve and enhance that capability and evolve what are the questions that we want to ask and what are the right data sources that are going to help us answer those questions. So completely agree with the sentiments before, and I would say this has been, commissioners have asked us to do this in the past, and many market participants have stressed the importance of the Health Policy Commission in doing these types of retrospective reviews as well to see what actually happened once we have the right years of data to be able to know. Any other comments or questions on the Beth Israel Leahy agreement?
The agreement took effect as of January 1st, is that correct?
The merger closed March 1st, I think officially, so I believe it would be March 1.
And then the first set of price increases that might have resulted would occur. Do we know when they would occur?
I think it would, they would have to negotiate as the new system for increases in the future, so it could be 2020, it could be 2021. It also depends when their contracts come up.
So much more to come on this topic as that moves forward. So shifting gears, and that was a great conversation, but I'm going to move through some of these other things a little bit more quickly. Shifting now to the care delivery side of the Health Policy Commission's work, I want to spend the next 10 minutes or so just updating the Commission on a new program that we are in the process of developing and launching. To walk you through this program, it's an academic detailing program. We'll tell you what that is and what our process to date has been. And the interim director for care delivery and transformation, Catherine Harrison, is going to walk us through these next couple of slides.
Well, good afternoon, Commissioners. Nice to see you. Great. So the legislature in its 2019 fiscal year 2019 budget did provide some funding to the HPC to develop an academic detailing program. The statutory language is here for your reference, but essentially we were asked to
put forward a program that would provide evidence-based information to clinicians, prescribers, to work with the Office of Medicaid in doing so, and to evaluate the effectiveness of the program over time. So, commissioners, you're likely familiar with this concept of academic detailing, but since it's a new area for us and sort of a strange term potentially for the public, let me just take a moment to understand and kind of explain what this is all about. Academic detailing is essentially a method of conveying information to clinicians that has some roots in the notion of pharmaceutical industry sales detailing, but is intentionally made to approach clinicians with evidence-based and as unbiased information as possible, but leveraging some of the same interactive techniques that sales representatives might use. So academic detailing typically is conducted in peer-to-peer exchange. So this is expert clinicians providing information to prescribers intended to support them in adopting best practices, in coming online with the latest guidance, etc. Obviously, physicians have tremendous access to information through journals and other means, but the recognition through academic detailing is that the way you convey that information and the opportunity for a physician or another prescriber to dialogue one-on-one with a peer is really important in terms of influencing their behavior. So that's generally what this notion of academic detailing is all about. It's typically focused on a particular clinical area or a condition, although this technique is also used in more public health focused ways, such as advancing screening rates or other evidence-based modalities. Okay. So with that kind of general background concept in mind, we've honed in on creating an academic detailing program that we intend to offer as a learning and quality improvement opportunity to our 18 HPC certified accountable care organizations. From all the data that are available statewide and with speaking with a few of our certified ACOs recently, we know that many of them are focused on pharmacy practices and interested in opportunities that we can provide to support that work. And because our HPC certified ACOs include a great majority of the major provider systems in the state, we think there's the potential for this program to have a nice wide reach. We also know that academic detailing has deep roots in Massachusetts. Some of the pioneering and leading experts in this particular field are here in the state and have established organizations and teams with really deep expertise in conducting these programs. So we intended from the outset to use this funding to develop a relationship with a contractor who would actually provide the detailing program. So over the winter, we did some stakeholder outreach to try to understand the interest and need for this program. We talked to several certified ACOs and also the Mass Health Pharmacy team to try to get a feel for what are their approaches currently to pharmacy management, to understand if they have particular high priority clinical areas with regard to prescribing, and to get a feel for whether or not they have access to data that would help us target either particular clinicians or conditions that might be right for our program. And we learned that ACOs generally are familiar with this concept. They often themselves have some form of educational information that they give to prescribers, often in the form of voluntary continuing medical education programs, sometimes literature as well. And with regard to data, there's just a tremendous amount of variability. Some of them do get information either directly from Mass Health or through the managed care organizations that Mass Health contracts with on prescribing behavior that would help them understand if there are particular drug categories or clinicians that are showing sort of outside the norm of prescribing patterns. But some of them have relatively limited capability to analyze that data themselves. In terms of providing input on the types of content they would find helpful or the design of the program, ACOs mentioned a wide array of areas they might be interested in, including diabetes, hypertension, asthma, behavioral health came up frequently. And they also urged us to prioritize working with an organization that could provide truly expert detailers who would be able to really on a peer-to-peer basis support their clinicians, and that we at the HPC consider the level of effort and resources it would take for the ACOs to participate in this program as we think about the design. So we considered all these factors, developed a procurement, issued that procurement in early February. And we did ask for, in this procurement, a couple of different types of models. Academic detailing can be a one-to-one educational opportunity where an expert organization would train its staff and those staff would go and detail. The other option on the table here is that ACO staff themselves would have the opportunity to be trained as detailers and then go out and actually do the actual educational visits themselves. So both of those options were included in our procurement. But we really prioritized looking for organizations with deep clinical expertise and experience in doing this work, including their ability to influence provider change. We received some very high quality bids, and we did conclude our procurement process earlier this month. We're in the very final stages of contracting with our selected partner, and I'm pleased to say I think we've identified and will have the opportunity to work with a really fantastic expert organization, a national leader in this area that submitted a really high value proposal and already has a library of really well developed materials and access to great staff who can do this work. So we're excited and hope to be able to announce that contractor very soon. From there, we will finalize the design of our program. We intend to try to issue a very brief survey to ACOs, both to raise their awareness that we're doing this and to get some final feedback from them on what topics and what type of program would be most relevant and interesting to them. We'll do an informational webinar when we have the final design of the program baked so that ACOs have a chance to learn about it. We'll put forth a very simple application process, which we hope will not feel burdensome to ACOs in order to select who might participate. And we'll get going. I think the first visits we hope to start to occur maybe by the end of the summer, early fall, and the contract runs for a year. So we look forward to working with the ACOs and our contractor on this.
Catherine, first of all, let me say that I'm very excited about this. I've watched this play out. Dr. Abel and Jerry Abel have been pushing this for a long time, and I've worked with him over the years. So what I'm about to say is not viewed should not be viewed in a negative way. Are we going to do an independent evaluation of what impact this has?
We've asked our contractor to work with us to try to evaluate the impact of the program. I think we will be able to do that. Metrics, exactly what we'll be able to measure, I think is still to be determined. We may have some limits based on the data that are available at the ACO level.
Well, but
So
if
we
we
have to
can
think
just learn about those practitioners that got this detailing, whether they changed their practices at all,
Yes.
what impact it had to change their practices
Yes.
in terms of costs or whatever. I don't
Number of prescriptions for a given product, even patient outcomes. There are a variety of ways to look at this. So we'll do the best we can.
And this is a one-time contract, it's not an evergreen, not renewable.
We do have the option to renew the contract, I think subject to available funding. It's not a lot of money to start with from the legislature, so we'll see how it goes.
Yeah, so this was $150,000 in last year's budget. We do think that amount of money will allow us to work with around 2 to 3 ACOs. The budget process, the legislative budget process is still ongoing, and it may be that the legislature includes additional funding in this year's budget, which we would then either be able to use to have more ACOs be part of the program or to extend that program further.
But David, I wouldn't, particularly in terms of the evaluation, I would think this is a potential for us to learn, and that we may want to use some of our research money for doing that. I mean, this has behind it is this concept that particularly physicians may not always be either using the most up-to-date information or being influenced. Where Jerry comes, he said, they're being bombarded all the time by these detail people on to sell more of the top expensive drugs and just skip everything else. And so here's an alternative to sort of play it out on the other side, which in principle sounds pretty good, but it just may be another one of those nice things that sounds pretty good that has no impact. So, I'm just saying that I wouldn't want us to sort of be constrained on the learning side solely by what this additional need is. It may turn out to be an important part of our particular drug issues.
I completely agree, and I think understanding the impact here is going to be really important. Understanding this is a pretty small pilot, and if we do think that there is an impact, that may lead us to recommend additional funds in the future. But I think it's a good to start a little small and to be able to see what the impact is going to be, and so that's why we're, it's a manageable program as it is, and so we'll be able to, with a contractor and with our staff, I think we'll be able to learn a lot.
The actual spread potential here is way beyond more funding from the legislature. If this worked, if Stewart said if we were able to redocument, because this has been documented in the past success, then value-based payment systems would be interested in it on their own. It's a way to.
There, I think also in light of the environment today around the epidemic around opioids, I think anything that we can do that levels the playing field and providing prescribing clinicians with unbiased information is a critical next step. And so I would not only support looking at some sort of research methodology that looks at whether the best medication is used in the best circumstances and the best time, but also whether those providers, the secondary measure is how did we manage to level the playing field and how do the providers feel now about the information that they're getting, and is this a reasonable approach given what pharmaceutical companies are there to do, which is to sell their products. And I think the ethics of some of the stuff that we've seen lately certainly suggests that somebody's going to level the playing field.
I think that's a great point, and there are a number of already developed materials that our expected contractor has around pain management, for example, non-opioid, pain management, as well as I think medication-assisted treatment. So there is a number of different areas that I think are very ripe in that topic as well.
Okay, thank you.
Great, thank you. So more to come as we move forward on that program. The next agenda item here, I will move through very quickly, just to give an update on our most recent investment program. So this was our $10 million Shift Care investment round. This board authorized the awardees for this program last July. So I want to give a brief update on where we are with this investment opportunity. As a reminder, this was an opportunity that was really focused on reducing avoidable acute care utilization, so hospital utilization, ED visits, ED revisits, admissions and readmissions. We did end up awarding 15 awards, ranging from around $500,000 to $750,000, and it is an 18-month implementation process program for these awards. As a reminder again, there were really 3 tracks that awardees applied for us for funding through this program. One was around reducing acute utilization by addressing what we call health-related social needs. So this could include food insecurity, housing insecurity, transportation needs, legal needs, and understanding the intersection between being able to help patients, complex patients, manage some of those issues and its impact on actually reducing healthcare costs and spending. The second track was really around increasing timely access to behavioral health care, and with a sub-track that many of our awardees, 8 or 9 awardees, are focused on initiating medication-assisted treatment in the emergency department for patients who present in the emergency department with an opioid-related condition or history. Understanding that emergency room physicians can prescribe buprenorphine at that time, but then our model is really around initiation and and a very close linkage back into community-based services for those patients. This is a model that was first piloted at Yale New Haven and had tremendous results in terms of reduced mortality, reduced overdose, increased retention and treatment for these patients. And we are going to have essentially 9 hospitals working on this exact same model across the Commonwealth. I think there is no other place in the country that is going to have as many hospitals and institutions working on this particular model of engaging patients in treatment. So we're very excited to launch and to get these programs running, and here today to say that we are launching these programs as of this month, as of April. So we really spent the fall contracting with the awardees, working through data submission. We did give them a 3-month preparatory period before they had to launch, but all 15 of our awards are now active, and some of them are actually starting to see patients. And so, as you can see on slide 27, we're at the very beginning stages of this program. We'll be excited to report back to you as these programs launch and begin to see patients. We do have an external evaluator that we've contracted with, Brandeis, specifically to evaluate the cohort of hospitals that are working on the initiation of treatment in the emergency department. So we'll have a very robust evaluation across hospitals that include community hospitals, but also academic medical centers. Finally, just want to show a great picture. We had a wonderful site visit to Holyoke Health Center to celebrate their launch of their program just last week. They are working, their goal is a 30% reduction in readmissions for patients with a psychiatric disorder. The model really is around bringing psychiatric prescribing and services in real time into the primary care setting, and so being able to bolster prescribing, and then having a community health worker do follow up with those patients in the community to make sure that they're adhering to their medication. So a great model. We had a great time at Holyoke Health Center, a really impressive organization treating a very complex patient population in a challenging area of the Commonwealth. Happy to take any questions on Shift Care launch.
David, I think these are great. I think these both addressing social needs and behavioral health are 2 critical areas for us to look at. I just want to put in a plug that it's not too early to be thinking about how we disseminate the information coming from these, as well as the issue of sustainability. I would hate for some of these to disappear just after the 18-month period. So,
never too early to be thinking about both of those things. And I would say, and perhaps at our next meeting or committee meeting, this program is just launching at the same time our previous round of the Healthcare Innovation Awards is winding to a close, and we've been able to get some really excellent information about the impact of those programs as well as their sustainability in the future. And so we'll have some great stories to tell about some past awards.
David, can I ask one question? You mentioned Brandeis as an evaluator for the behavioral health program. How about evaluating the social needs aspect? Are you using an evaluator for that as well? Because I think I'd be really interested to hear how successful that is as well.
So as part of this round of awardees, we actually did require that they have their own plan for evaluation, and did fund as part of the award that evaluation. So in some of the cases, those organizations have themselves contracted with evaluators to do that evaluation. We are helping to guide that and advise on that, but it is something that we're not going to be directly doing ourselves. In the case of the medication-assisted treatment in the emergency department, given that there was such a good cohort, we did think it was valuable to have one centralized evaluator rather than 8 separate evaluations to really understand that. That being said, of course, we're going to be collecting qualitative and quantitative information on essentially a monthly and quarterly basis from all of the awards. So even though they will have their own third-party evaluators, we will absolutely be doing our own assessment of the program and its successes. But especially in this round of funding, there was a heavy emphasis on making sure that we're building the evidence base and contributing to the evidence base about what actually works here, especially in areas like this where these are new, new areas, and yet a lot of interest from locally and nationally about how do you actually make a difference by addressing health-related social needs, for example. And so I think will be of high interest across the country. Great. So the next topic to run through in the next couple of slides, and I'm going to use my executive director prerogative to kind of skip around a little bit here, but did want to just, if moving to slide 32 and to slide 33, this is an overview of some of the different research projects that we're working on and planning to work on this year in calendar year 2019. I would say that many of these research projects are informed by you and the discussions of this board. They're informed by topics that came up at the cost trends hearings, as well as topics that when I meet with the HPC's advisory council are of interest to the market. Some of these are new topics, as you can see, while many of them are follow-on analyses or deeper dive into topics that we have previously examined. And these align very closely with the recommendations of our annual cost trends report. Kind of moving a little quickly here, on slide 32 you can see many of our kind of research projects more in the market oversight and transparency space. A number of pharmaceutical spending items, one on insulin price growth, which we actually have a little bit more information today to discuss, so I'll move quickly through that. We are in the final stages of a report on white bagging and brown bagging, which is around drug distribution channels and what the impacts on quality and access and cost have been for these different ways of getting drugs into the hands of physicians. These are typically physician-administered drugs. We have a mandate of a study on the impact of drug coupons or copay assistance programs, and that is a new mandate and study from the legislature and the governor. And we're also looking at the role of pharmacy benefit managers in terms of potential price markups that they have. What are they charging health plans for drugs compared to the actual acquisition costs of those drugs? This is a black box, really, and many states and nationally are really trying to untangle the flow of money from and the role of the pharmacy benefit manager here. Some states have gone so far and have seen that there are significant upcharges that the PBMs have put in place. Ohio comes to mind, where their Medicaid program identified hundreds of millions of dollars that was related to price markups for their Medicaid managed care organizations through these PBMs. So a great deal of interest in that particular area. Continue to work on out-of-network billing. This continues to be a top policy priority for the agency, and working on an analysis that would try to identify what some different levels of fair and reasonable reimbursement are for out-of-network, and so trying to compare both what our average in-network rates, what our average charges, what does Medicare look like, and being able to put those side by side. The issue of what is fair and reasonable reimbursement and payment is the true most challenging policy decision as part of the out-of-network billing conundrum, where there is broad consensus to get the patients out of the middle of these situations. There's not broad consensus on what actually the payment should be for those services, and so hope to bring some new data points to bear on that. Market retrospective we'll talk about in just a minute. Continue to work on hospital outpatient. This was a big question that this board continues to raise and others continue to raise. What is driving the big increases we've seen in hospital outpatient spending? What services are moving into that category? Are they moving from the hospital into inpatient to hospital outpatient, or is this again shifts from community or independent physicians into hospital outpatient? And then some follow-on work on avoidable ED and provider organization, performance variation on low-value care. The last thing on this list is administrative complexity. So this was a big priority and recommendation out of the cost trends report to be able to identify areas of administrative complexity that may not provide value. We have been heavily engaged in this research topic to date and meeting with different stakeholders and different state agencies, and would expect to come back to this board at the July board meeting for a more in-depth conversation about what we've learned so far in our efforts on this particular topic. So this is a little bit more of the market and transparency. The next slide is care delivery, but I'm happy to kind of pause here for a second and see if there's questions or comments on this slate of research projects.
Yeah, this looks like a great list, and another long list in the slide below, so I feel like we're tackling a lot here. But I was just wondering, how do you see, or in what ways, the post-acute spending play into any of these reports? I know it's clearly a big area that we've said we're way outside of the norm across the country. It's a big area of savings potentially. So is that the other settings within household outpatient, or is it not covered here? And if not, how do we start to really hone in on that piece of the pie?
So I think you're right to observe that we don't have a special project on that point, and certainly open to further conversations on that. I think the one place where it does fit in is within the healthcare market retrospective. So one of the things that we do plan to identify there is, over the last 7 years or 8 years, how have we seen the shifts in care for patients leaving the hospital? Are they going to skilled nursing facility? Are they going home with home health? Are they being routinely discharged? Be able to understand both at a statewide level and then even for individual organizations what those trends have been over the last couple of years, for what types of services or what types of patients are we seeing that they're more likely to go home with home health now than maybe 8 years ago they were much more likely to go to a skilled nursing facility. So I think in terms of patient flow and trends, definitely will be a component of the market retrospective.
Hey, David, on the PBM question, how are you gaining information? What's the process? Are you doing it directly? Go ahead and say more.
Yeah, so there's currently we're working on two separate analyses. One would be for the Medicaid managed care organizations, and what we do, there is federally reported information about essentially what the Medicaid managed care organizations pay for the drugs through the PBM, and we can compare that to, again, national data around what is the acquisition cost of that drug, and expect to calculate the delta between what are PBMs charging for these drugs versus what we know to be the NADAC acquisition costs. We're also going to be able to do this through the claims data on the commercial side. So through there, we'll be able to understand, again, what is being charged for these drugs, again, compared to what the acquisition costs. Now that delta is revenue that we believe is being retained by the PBM, and they use some of that revenue to pay for the pharmacist for the dispensing of that drug. How much they pay that pharmacist is not known and is not public. So there are definitely gaps that we have in the data that while we may be able to understand what the delta and the difference is, we do not have great insight into what is that delta being used for by the PBM. Are they sharing some of that money back to the health insurance company? Are they retaining it as profit? Are they passing it through to the pharmacist? Anecdotally, we do not believe that is the case, but there is going to be some limitations in terms of what we're actually going to be able to say.
Yeah, so as you know, rebates are the way they make you feel better about paying $20 and giving you $7 back. $7 is your rebate. So it's what happens to that $13 is the question. And they have programs, lots of programs. Mail order, which probably is very cost effective. I hope that when you get the number to see what the delta is, that you are in a position to ask for information about those programs. Because I think that's where the money is.
Yeah, and I think
I'm not sure whether there's value there, but that's where the money is.
I anticipate that our analysis will result in more questions than answers. And I think it is very much those questions that would be the next phase of work. What exactly, where is that money going? What is it being used for? Is it providing value to patients and providing value to the system? I don't think we'll be able to answer those immediately, but I think the analysis will solicit the basis for that further level of exploration.
And will the process then be the executive director of the Health Policy Commission sending a letter to Caremark or to Express Scripts, or how does that work?
So I think this is an open conversation for the board. I think we could anticipate inviting PBMs in a public setting to react to that analysis and to provide more information. Maybe something that we want to talk more about at the cost trends hearings and use that as an opportunity. So I think open for suggestions and feedback on that.
I hate to, having just spent a very interesting day in Washington on this issue, the knowledge base has really grown very substantially. And so you have the administration in Washington coming up with a PBM plan, which I think we probably want to bring up at this meeting. Then you have the amount of information that's been generated about this, and then the battle over, forget about the markup. Suppose it turned out that PBMs were perfect in terms of taking all the rebates and giving it back, say, to the insurance companies. The question is, what do the insurance companies do? And the big battle, of course, is do they, in fact, lower the price of the drug for the people who paid the bill? Or, as many of the insurance companies are doing, they're using the rebates to lower the premiums for everything. And as a result of that, if you happen to be stuck buying that drug without the rebate, what you're buying, you wind up paying. So the question is, who should the beneficiary be? So the administration is now saying, you got to turn all the money back to the people that bought that particular drug. Well, that could generate increases in premiums across the board because, so anyway, well, I'm not trying to, when we have this discussion, I've been impressed by the amount of information and discussion going on in Washington on this subject. So we, it's a really complicated issue. So, we're part of it at the state level, but it's not like, there's been a lot of work done on this within the last, I would say 3 to 6 months. I was pleasantly surprised.
Yeah, I think pharmaceutical spending generally has been, just an incredibly robust discussion, both at the state level and at the federal level in the last year. The role of PBMs is one that comes up often, and I would say some of the legislative proposals last year did include new requirements around PBM interact regulation with the state, an ability for the Health Policy Commission and others to get more information from pharmacy benefit managers and manufacturers. So there may be some state level progress that would give us more authority to get the type of information we need to truly answer some of these questions and to be able to better understand, to both of your points, the flow of dollars here and to whom are these benefits accruing, because right now it's still very much a black box.
I would just note that Mass Health recently updated its policies to require Mass Health managed care entities to report on payments to PBMs to get at that level of information and data on how much those managed care organizations are paying towards PBMs to be able to look at what is the spread that PBMs are accruing on behalf of the, or I guess
It's a great list. I mean, I think this is probably already covered well, but one of the things I think we help a lot with is turning the lights on inter-provider variation among provider entities. We've done that obviously with pricing, and we should really continue to do that. But almost every topic you list here makes me wonder what's the variation among providers in the state, and then regional variation. Different parts of the state. I hope I'm factoring that in.
Yeah, and that we have now built that capability to be able to map, patients to provider organizations, and then be able to understand spending differences, pricing differences, utilization differences, patient complexity differences. So I think in each one of those cases, we'll be able to understand that variation among provider organizations as well as even regionally as well.
Yeah, I was thinking this really exciting project on academic detailing. The next phase of that would be to hotspot the state and say which drugs are being used where, and which provider entities that really that's where the detailers ought to go. That would be great to be able to link those. Yeah.
So on the next page here, I won't walk through all of this. The first one is something that I do hope to spend a few minutes on later today, which is a new report on the availability of providers that serve patients with co-occurring mental health and substance use disorder. We are also working on some updates around the impact of the opioid epidemic on hospital utilization. This has been a report that we have produced in the past and hope to update it with the most relevant information, as well as impacts on neonatal abstinence syndrome. So some updates of some past reports where we get some new data. The next two buckets I won't walk through here, but really are around disseminating and creating information about what we've learned through our investment programs and our certification programs, and continue to think about the learning and dissemination priorities of the agency. Primary care workforce, I'm going to ask David to just say a minute about that, but to skip down to the rest of these, we are looking to contract with someone to write up do some interviews for us on alternative payment methodologies and the lack of progress that we've made in the last couple of years. Interview some health plans, interview some providers to try to understand what are the barriers that we're seeing in terms of APM adoption, specifically in the commercial space. But David, you want to say a word about the primary care workforce piece that we're exploring?
Sure. And here the focus is mainly on nurse practitioners, and this is partly related to scope of practice laws that in the state we've talked before about how we're different from a lot of other states around here in having restricted practice. And we want to even just understand the background of how many NPs are there in the state, how many are providing primary care, how many are acting as a patient's primary care provider, whether assigned by the payer or the plurality of the person's visits are to that nurse practitioner. How many visits are they providing? How the extent of incident to billing, where the NP might provide the visit but bill under the physician's NPI and end up with a 15% higher charge, which is allowed in some circumstances, but it's hard to figure out how often it happens because you don't really see in the claim who was that provider, but we have ways to get around that. And then finally, are they providing more care in rural areas in the state or to mass health patients versus commercial patients? So we hope to have more information on that soon to just help out with the discussions that might happen this year in this session.
David,
Yep.
just a question. As you look at that, are you looking at prescribing practices as well?
That's a good question. We do want to see, to compare patient outcomes by who your primary care provider is, and prescribing is, it would be natural for us to look at that too, especially if we have certain things to look at. Sure.
In apropos of our previous conversation.
Yeah, there have been some studies done on antibiotic prescribing by provider. That's good.
Great. Well, more to come on that. As you can see, we have a full agenda. Skipping ahead, I'm going to jump around the agenda just a little bit here. Skipping ahead to slide 37, the next couple of slides are just some upcoming previews of some publications, but moving to slide 37, wanted to spend a minute to just let you know and let the public know that we are today releasing our next issue of our HPC data points. As a reminder, data points is our online small briefs series. We typically use this to explore a very specific topic and then use the online capability of Tableau to be able to put graphs and charts online that then members of the public can go onto our website and be able to manipulate the data and look at different findings that arise out of that. So this particular issue is on insulin price growth and patient out-of-pocket spending. This was a topic that we actually presented most of these findings at the benchmark hearing, if you'll recall. So what we did here was really, this was an APCD analysis where we looked from 2013 to 2016 and identified patients, commercially insured patients who had an insulin prescription during that time. And then we're able to track what we saw as both the spending growth for those patients over that 3-year period of time, how much of that was related to insulin price growth, and what impact that has had on patient out-of-pocket spending. So I'm joined here by Laura and Hannah, who worked on this project. And so I think maybe let's, in the interest of time, wanted to focus maybe on slide 40, which is a new analysis that we did not present at the benchmark hearing.
So Sway is going to be helping us out on Tableau, so you can see how this works in real life on the website.
So, as you all know, insulin spending is a large proportion of the spending for people who use insulin. And so, in this new visual, which we'll go to the next one. Yeah, so we'll go to the next visual. Thank you. So this visual, which I encourage you all to look on your own computer, it'll be much easier to see, but wanted to kind of demonstrate the capability of what we've done in this data points brief. So we looked at the specific insulin products to further study the growth of the spending category. This visualization has 2 different views to understand the price growth of analog insulin products. Both views have information on a price per unit of insulin basis, which was used to establish comparability between products. And so the first view displays unit price growth by manufacturer over time, and the visualization allows you to compare 1 or more manufacturers and different delivery modes that products might be used in. The symbol shape and color conveys the information as well, and the size conveys the relative volume in the study population. For example, if we select reliability and Novo Nordisk, which Sway and
think what was most striking for me in this data is this graph on slide 40, where we can break it down by the top manufacturers, and you can see that the price growth of per unit of insulin for these top manufacturers, every one of these manufacturers increased the prices in almost a lockstep fashion together over this period of time, and it is inescapable to raise some questions about whether the competitive market is truly working to provide value to patients in this area where competing manufacturers, again, moving in the exact same direction over the same period of time.
So is there ever an opportunity for us to submit a report such as this to the legislature even though they haven't asked for it? I mean, I'm looking for ways to influence policy, to influence legislation. Is there do we see any next step use for this report in terms of driving policy and legislation?
So we absolutely share everything that we produce with our friends in the legislature, whether they ask for it or not. And we had in this year's cost trends report, we did make a number of recommendations around strategies and reforms to address pharmaceutical spending. The governor had a very robust proposal in his budget. The House has taken up a different version of that proposal. And so these are very active conversations happening on Beacon Hill in terms of potential policy solutions. And we do think that this data continues to support and provide the evidence that we do need to do something about pharmaceutical spending, where we see these significant price increases that are also leading to affordability challenges for patients. And this is for a very basic medication that is needed to maintain good health and good outcomes. All right. That will be up on our website. So thank you, team, for moving through that quickly. That was great. As noted, a lot of more interesting information on the Tableau if you go through the data points. The next topic I'll handle myself to talk about through very quickly. So prescription drug coupons. There was a recently passed legislation on January 2nd of this year that required the Health Policy Commission to conduct a study on the impact of prescription drug coupons. These are manufacturer-developed assistance programs that help defray the out-of-pocket costs for patients when they're picking up their drug at a pharmacy. And the allowance of prescription drug coupons or these copay assistance programs was prohibited in Massachusetts until 2012, when there was a special law that passed that for the first time authorized these coupons to be available in Massachusetts. Massachusetts was the last state in the United States to allow for these types of coupons. That initial law that authorized for the first time these assistance programs did have a sunset on it, so that authorization was intended to sunset. That sunset has been extended multiple times. But in the last extension of the sunset, the governor proposed and the legislature agreed to mandate that the Health Policy Commission do a study about what the impact of these assistance programs has been since they were introduced into Massachusetts in 2012. On slide 47, you can see here what our mandate is, including understanding how many of these coupons are being offered, what is the value of them, what of any impact they may have on generic versus brand utilization or among different brand name drugs. And really broad questions around the cost, quality, and access impacts of these particular programs. So this is a new topical area for the Health Policy Commission. And so we are leveraging all of the data sets that we have to be able to try to answer this question. So on slide 49, slide 48 I skipped over, but does kind of lay out a taxonomy of where these coupons, the different types of drugs that may have these coupons available. I would note in Massachusetts it is still prohibited that to have a coupon where there is a generic equivalent for a brand name drug. But where there are two brand name drugs that may treat the same condition, those coupons are allowed in that particular circumstance. But where there is a clear generic, those are still prohibited in Massachusetts. The one thing I guess I would just note for you here that has been a unique challenge is getting data and information about these coupons and what their value is, how often they're being used, where and for what drugs. This is information that is not included in the claims data because this is really at the point of sale or the point of dispensing. And so we have been exploring different commercial vendors that do collect this information and this data to see if we may be able to contract with a vendor that does this to be able to provide the information we're going to need for this study. That has taken some time, but I think we are hopeful and confident that we'll be able to get the type of data and information we need to do this study. Don't have a firm answer for you yet today, but did want to highlight that getting the information to even do the study has been consuming most of our effort to date. We did have engaged with contracted with an expert clinical pharmacist to consult and to advise us on this study, and we have engaged with another number of academic experts as well. But as you can see on slide 50, I think the important thing here is just the timeline by which we think that we'll be able to complete this work, understanding there's a lot of urgency by the legislature and the administration to have this report done. I think we expect to be back in July with preliminary results and findings, and then September at our board meeting would have a final report to prepare for consideration by the board. So more to come on this. The last thing that I think is just most important to highlight is that we do want to have a listening session and invite the different stakeholders to provide their perspectives on this particular issue. This is an issue that does have some controversy and disagreement among industry stakeholders about the value of these programs. So are putting a wide net out both for health plans, consumer advocates, pharmaceutical manufacturers, and vendors to attend a public listening session that I think Commissioner Cutler has agreed to participate in. All commissioners are of course welcome to attend, but that will be on this date. So more information, we'll put up a public notice of this listening session and some of the questions we hope people will answer, but did want to have an opportunity for the different stakeholders to formally weigh in as we complete the study. Seeing no questions or comments on that, I think the next topic really is around this healthcare market retrospective. Understanding we have a little less than a half an hour left in this particular meeting, I want to spend about 10 minutes just updating you on what we're thinking here, because this was a prime topic of conversation at the beginning of the meeting, and then we'll close the meeting with some findings on our report on co-occurring disorders. So I'm going to welcome back Kate.
Thank you.
Our Director of Policy for Market Performance, and Megan again, to kind of quickly give you a sense of what we're working on here, because I think it is very responsive to everything you've been asking us to work on.
So I'm very excited to hear the enthusiasm from all the commissioners on this topic. We are very excited to be working on this topic as well. So there are just a few pretty high-level slides, because really what we wanted to do as part of today's conversation was to hear from you, hear what your thoughts are and priorities are as we're undertaking this work over the coming months. So this first slide really highlights a lot of the things that you know, that the HPC has been monitoring the market since 2013. As Megan noted earlier, we've had just shy of 100 transactions that our team has reviewed during that time. And the healthcare market is changing rapidly. These affiliations have resulted in continued consolidation of both hospital and physician services. And at this point, the vast majority of primary care services are being delivered by a pretty small number of large systems. And while in some cases, providers have suggested that these affiliations will lead to improved efficiency and lower spending. Initial looks at some of these past transactions haven't shown very significant savings. And so I did just want to emphasize that we have been doing some of this work on an ongoing basis. So folks may recall we spoke about this back in fall of 2017 at our then the CTMP committee meeting, looking at some of the past transactions for which we had enough years of data to say things in particular about changes in prices, changes in spending, changes in community appropriate care and the location of that care. Actually, the transactions for which we could say the most were ones involving Beth Israel and Leahy providers. So that work actually ended up being folded in by and large into that CMIR. And so in that CMIR, as you may recall, we noted that the providers that had been acquired, we hadn't seen that there had been big price jumps relative to comparators in the area. We didn't see big changes in spending either, though. And where there were cleaned goals of achieving savings from redirecting care, we did see that for the affiliations that were acquisitions only, there had been some evidence that of success in redirecting some care to lower price settings, but we hadn't seen an overall big change in spending. So that's kind of the starting place of where we've done some of this work on past transactions. But we really see writ large that there is persistent market dysfunction, and so one of the goals of this work is to both highlight the existing dysfunctions in the market, look back at some of those past transactions now with more years of data, more transactions under our belt. And then another core goal of this work is to look back and update some of the challenges that we've identified in other pieces of work. And so here in particular, as folks may recall, we did a major report a few years back called Community Hospitals at a Crossroads. This was a core graph that kind of spelled out a little bit of the storyline in that report, kind of detailing some of the challenges facing community providers and independent providers in particular. So as you see in the top right of this chart, continued consolidation of providers, both through corporate mergers and through contracting and clinical affiliations, has generally had the result of hardening referral networks and resulted in more care going to AMCs. As more care has gone to AMCs and teaching hospitals, community hospitals have frequently seen lower commercial volume in particular, which then reduces their bargaining leverage with commercial payers, contributing to lower commercial prices, which then contributes to financial instability in some cases, or at least more limited resources for those providers to invest in a changing, in a quickly changing care delivery environment. And then that contributes to the pressure to affiliate with larger systems that may have greater resources. So our hope is to highlight some of these features again in our market and look back to see to what extent they are changing either for better or for worse, or staying the same. So we, as I said, expect to update and expand on many of the analyses that contributed to the Crossroads report, assess continued areas of market dysfunction, and look at the impact of some specific transactions over the years. We've also, we plan to be working closely with other HPC teams to develop findings, and we expect to provide updates in future public meetings, including the Crossroads hearings, as well as potential future publications. But the scope of this work is quite broad, so we really wanted to hear from you as we are mapping out this work over the coming months. Where would you like us to focus most?
I was just thinking, Don gave one way to start earlier, which I thought was a terrific way to go. And I was going to sort of second what Don said about places to start. I'm trying to get a sense, as I think Don was, of kind of which sorts of which sort of commitments ones are easier to accomplish, and therefore when we hear them, we should say, okay, yeah, that's feasible. Which ones are really very hard, in which case we ought to be looking much more skeptically. You know, when the parties say, well, of course we'll be able to do this, and we'll have to say, no, no, no. In order for us to believe that, we're really going to need to see a lot more detail about how we're going to do it, because just in general, that's a super hard thing to do.
I'm super excited about this, thank you, can't wait. Yes, so the way I stratify this, for starters, is a little bit the way you've done. One is overall trends, what's really happening in the Commonwealth, continue to keep an eye on that. The second would be what I recommended earlier, let's really focus on some case studies, and the criteria I gave you before, I think might be right, which is the changes that were consequential, explicit promises or offers, you know, of what should have happened, and then they're right, that it's been long enough that we're not going to hear, oh, it hasn't been long enough. So that case studies. The third, which you didn't mention, which I think might be kind of cool to look at as positive deviance, which is not just averages, but is, are there any players, any sectors, any geographies, any types of delivery where, wow, they've really done something that we're helping people do, and then we can dig in deeper and understand why, what's actually happening.
Let me build on that last statement, and I don't want to be either paint this as a beautiful picture or terrible. I don't know the answer, but I'll tell you the number one question I get asked any time I talk about Massachusetts, when I tend to focus on the big things, on all the good things we've done, and how we've managed to get the growth rate down, and how we've gone from the most expensive state to the second most expensive state. With great pride. Thank God for Alaska. But the question they ask me all the time, which I really don't, what did you do to bring all these costs down? And I come up with some flippant answer. But the reality is I don't know. And particularly they say, what kind of regulatory power do you have to make this happen? And I go, well, if you're into prayer, you know, I mean, so all I would ask is you think, you know, we can find all the things that people promised that didn't do. But I don't want to lose sight, and I would love for you to give me a decent answer. So the next time I get my finger out of my mouth, I can actually articulate. You know, I can say, you know, the benchmark did it different, people did. I mean, I don't know. So I'm just saying that let's put this in the context of the state that really, on the whole, has really made substantial, without progress in terms of changing some of the dynamics, without really understanding. So as we do this retrospective, we ought to be conscious of that total picture. Not that I want to sugarcoat it.
I love the opportunity to correct the economists. We haven't reduced costs, we've reduced growth.
Say it that way, you're absolutely right.
I'm curious, there were a number of requests to us for contract affiliations that had promises of quality improvements as well, and sort of didn't answer what the contract is going to do for the organization. That's a set that I would like to see some analysis on.
Great. Well, more to come on this. I think we'll probably have some time at one of the committee meetings to dive a little bit deeper in what we're thinking here, and expect to be back before this board with more details on what some of the case studies that we think would be most ripe for that deeper dive, and to let the public and those parties know that we're going to be doing a deeper dive. All right, great. Well, our final agenda item today, thank you, Kate and Megan. Our final agenda item today is to close out with a presentation on another piece of research and work that we've been working on for well, almost 2 years actually at the Health Policy Commission, and have finalize the report. We did send it to you all last Friday, and so hope to present our final findings today, and then after this meeting be able to finally issue that report. So shifting gears from the market back to more of the care delivery side, as you can see on slide 58, this was a study that the legislature asked us to do as part of one of the opioid reform bills that's passed in the last couple of years. We were charged to do this in consultation with the Department of Public Health and the Department of Mental Health. What really was around assessing the availability of providers, as I said before, that can treat patients with co-occurring mental health and substance use disorder. And as Adrian will quickly go over in a second, this is a really important part of the delivery system where there is a real connection between patients that have mental health disorders and mental health and substance use disorder, and candidly where we found that there are some gaps in the provider system in being able to really provide integrated care for these patients and thinking about both sides of those conditions. And so the legislature did ask us to, one, just try to understand where are there providers that are duly licensed to be able to provide these types of services, and to do an even broader assessment of the sufficiency of that capacity, and finally to make some recommendations. So with that, I'm going to turn it over to Adrian, who really helped lead this work along with Carol, and we'll go through these findings relatively quickly, but if you have interest and questions, please feel free to stop us along the way. I would note we did present these findings at a committee meeting actually in the fall, and had a great conversation with committee members at that time of our care delivery committee, and Commissioner Cohen has been as well instrumental in the development of this report and reviewing this report. And finally, would also acknowledge Secretary Sutters and Undersecretary Peters, who also were heavily involved in reviewing the report and providing a lot of feedback on this report. So thank you to all of you. So with that, Adrian.
Thanks. Right. Okay, so thanks for the sort of background and context for the report we're presenting today. I'll transition now to some additional background information which will be reviewed for those present for the November CDT meeting, and we'll get into some of the survey methodology, the findings of the survey at a high level, and conclude with recommendations, which will be presented for the first time here today. Excuse me. So this slide points out that we combine some different estimates around prevalence. Unfortunately, as Carol will discuss in recommendations, there are limited data around prevalence of co-occurring disorders, and frankly around mental illness and substance use disorder distinctly. So using those numbers that are out there and census data, we conclude that approximately 236,000 Massachusetts residents are affected by co-occurring disorders, representing about 5% of the Commonwealth's population of adults. Excuse me. Patients with mental health concerns are at higher risk for substance use disorders and vice versa, and this is a really potentially valuable opportunity for some of the recommendations we'll get into at the end. But I think in terms of clinical value here, co-occurring disorders are complex, and this is an opportunity for provider-side investment, training, etc., for improved patient outcomes long-term. So looking here is a summary of sort of licensing arrangement we have throughout the state as it pertains to the topic of co-occurring disorders. This graphic illustrates the complexity of that structure, and there are legitimate historic reasons for the way in which it's organized presently. We believe the graphic, if anything, highlights our shared understanding with the OHHS of the potential value of streamlining some of the processes and the arrangements here. I'll now turn to Carol, who will describe our survey methodology and some of the findings.
Sorry, thank you. So the first thing we did was to create an inventory of providers who treat co-occurring conditions, and we looked at multiple data sources for this. And really, we found there's no publicly available data set that just singly identifies this. So we used licensing data from DPH, the Bureau of Healthcare Safety and Quality, the Bureau of Substance Addiction Services, as well as the Department of Mental Health for the inpatient licenses. And really, it was a process of lining up every facility and looking at all the licenses they had to identify those that had more than one license treating both. In this graph, we can see that of the 586 outpatient mental health clinics or substance use counseling and treatment providers, about a third were clinics that held both licenses. This is the inventory that's been mapped across the state. Really, you can see they're spread throughout the state. A preponderance are in Boston. And you can see that most of them are the orange crosses, and those are those clinics with the SUD counseling service as well. This graph is going to be released online in Tableau, so you'll be able to dig in and filter on various aspects of it. In addition, we looked at the same set of providers, and we looked at driving distance from each zip code, so that we could see where there's areas of the state where it's a longer drive time to get to. And in the Cape and Islands, half the people live more than a 15-minute drive. In the Berkshires and Western Massachusetts, it's well over 30% drive more than 15 minutes to the closest dually licensed clinic. So we found that licensing data was not really sufficient to analyze what was going on with providers, so we also conducted a survey. Again, we gathered data from multiple sources. We used SAMHSA provider directories as well as the licensing data. And we gathered key contact information from the Massachusetts for Behavioral Health Care and the Massachusetts Association of Behavioral Health Systems. We also contracted with a vendor who cleaned up the email addresses, added some more email addresses, and then designed a pretty complex survey. Sent to all the provider organizations. Each organization was asked to answer for all of their sites. So we got responses for about 405 provider sites and facilities. We also surveyed individual clinicians. We didn't get many responses. We had 170 responses. Those are not incorporated into these results in the rest of the survey. And now here is the first results. One of the main questions we asked all the respondents was, do you treat mental health primarily, substance use primarily, or treat both conditions as a primary service? And we found that nearly 60% of the respondents indicated offering both mental health and substance use disorder treatment as a primary service. It's certainly a higher percentage than those that are licensed to provide both. Should be noted, even though the facilities aren't duly licensed, the clinicians who work within the facilities, their professional license allows them to treat any behavioral health condition. But while there's a lot of dual providers that serve people with co-occurring conditions, it's really not easy for people to find this information. It's not collected and transparent to people. Now I'll turn it over to Adrian.
Thanks, Carol. So this slide and the following are formatted similarly. The bold bars, which I think in all cases are the tallest sections of each column, represent the survey respondents who claim to serve patients with both disorders primarily, while the blue indicate those who identify serving patients with mental health diagnoses primarily, and the orange representing substance use disorder primarily. So what we see here in this particular graph are potential access issues for transitional age youth, patients with a history of judicial involvement, and folks who are deaf or hard of hearing. On the following slide, for the sake of time, I won't spend too much time here. These are all, again, in the report. This one is similarly formatted again, but on the y-axis you have different mental illnesses, and the far most left three, anxiety, PTSD, and mild moderate depression, still do not have complete rates of treatment by any of the three types of survey responding providers. We'll also highlight an eating disorders treatment access issue potentially on the far right-hand side. Transitioning to access to medication specifically, both medication for addiction treatment and psychiatric prescribing is both are valuable to the population with co-occurring disorders. We see here that providers reported a range of prescribing arrangements from the far left being on-site or local access to prescriptions for either of both disorders, and on the far right, the red columns indicating no such arrangement. And want to highlight the red, even though it's a bit unfortunate for now. I think it's an area of major room for improvement, an area where many of the investments and recommendations we made later in the presentation and in the report ought to be focused. Finally, in terms of results here, we have two pie charts on the left for patients who speak English and on the right for patients who do not. This is indicating a potential access disparity based on timely access to a first appointment based on language spoken and language in which the appointment would be delivered. So nearly half of providers indicated a wait time of more than 3 weeks for patients who do not speak English, whereas about a third of providers indicated such a wait for folks who do. Fortunately, long delays like this are mitigable through workforce-targeted policy change, which is a great transition to Carol's review of our recommendations.
Can I just make sure I understand what
Yep.
only half the physicians who treat substance use disorder patients prescribe? Is that what I interpret for you?
This was a survey not of physicians, but of provider organizations. So these are mental health and substance use provider sites like community mental health centers or BSAS licensed counseling, and it's about the site's prescribers. So it's out of the scope would be independently practicing physicians.
But to kind of walk through this slide really quickly. So on slide 68, Carol, these are providers who did in their survey say that they can treat patients with co-occurring disorders. So this is now a subset of all of the survey respondents. So this is a subset of 100 respondents who said we do treat patients with both. And then we asked the follow-on question, well, what are your prescribing capabilities? And I think what was most striking for us is on the left-hand side of this slide, when the providers who said, yes, we can treat patients with co-occurring disorders, there was there's a significant portion of them that did not have any arrangements for actually doing substance use disorder prescribing. And so that appears to be a gap here where I think our statement is that if you're going to purport to provide substance use disorder services and you have no arrangement for actually doing substance use disorder prescribing, that is a gap in the system, because we think substance use disorder prescribing is integral to being able to treat patients with substance use disorder. So here where 23 of the respondents said that they had no arrangement for being able to actually do prescribing, that was a striking finding for us.
Because that's like far and away the most effective treatment for substance use.
Certainly evidence-based best practice, yes.
Did they have other arrangements other than Medicaid-assisted treatment?
The question was targeting specifically prescribing arrangements. I believe, if not literally, it was certainly implied based on the context of the series of questions in which this fell, that it was limited to the context of psychiatric or substance use disorder prescribing. Does that answer your question?
50%'s a nice hit rate on the survey. When exactly did the survey take place? Was it last fall or?
Last spring.
So a year ago. Yeah. And is there any plan to, with what ease can we resurvey or contractor resurvey? And what I'm getting at is self-treatment with CBD and THC now is part of the game, and it'd be really interesting to see that overlay. I defer to Marty, but it's a simple additional question to ask about self-treatment
So I think to answer your question, I don't think we currently have any plans to do a resurvey. I think that is certainly, an option for us. One of our recommendations is to try to see if there's a more systematic way for collecting some of this information, rather than having to do a survey, which was, was intensive. The survey itself, with all of kind of the different choice decisions, ended up being something like 300 pages if you printed it all out. And so one of our recommendations is that, if we're going to try to understand where these providers are and what their capabilities are, is a survey the best way to do it. But nonetheless, I think a resurvey is absolutely on the table.
I don't wanna make it a big project,
Yeah.
but you can make 20 telephone calls on random, sort of, those who responded.
And we do know who did respond and have all of that, all of that contact information available to us still. So Carol's going to just quickly walk through the recommendations on slide 70. To preface these recommendations, I would say the issue of availability and access to behavioral health care writ large is obviously a top priority for the Baker administration and for Secretary Sutters. And the issue really specifically around how do we kind of think about these patients with co-occurring disorders is one of her top priorities. And so many of our recommendations, as you'll see, are really in support of actions that the administration is currently working on. And so as you'll see on these recommendations, many of them are the Commonwealth should continue, the Executive Office should continue, and really meant to be a statement of support for a lot of the activities that are ongoing. I would also note that this is also a topic that the Blue Cross Blue Shield Foundation had an event on earlier this year, and also had a second set of recommendations, policy recommendations. Our recommendations are very much aligned with them, with those as well. So needless to say, I think these are important and very important directionally, and very consistent with, I think, where the community is at with a lot of these ideas. So with that, Carol, maybe just quickly walk through our recommendations.
Okay, good. So our recommendations fell into 4 buckets: licensing and regulation, integrated care models, workforce development, and payment policy. Licensing and regulation, we recommend a systematic approach to identifying and monitoring the prevalence and the capacity to serve patients with co-occurring disorders. We also recommend streamlining license processes. There's actually efforts underway right now, so DPH clinic regulations are currently under review. And we also make recommendations about wait times, and again, for residential care, Mass Health has been addressing this with the 1115 demonstration, which now funds residential services for substance abuse. And also the Bureau of Substance Addiction Services is procuring 26 additional providers to provide co-occurring residential rehabilitation. In the integrated care bucket, we do recommend additional efforts to build more innovation and evidence-based models. Such models could include integrated dual disorder treatment, dual diagnosis enhanced, some open access scheduling. We also think that primary care providers and community-based social services organizations play a really important role for screening, referral, and coordination. And we want to highlight that it's very important as these policies are developed to identify cultural and social needs of the most vulnerable populations. And we discussed earlier medication-assisted treatment or prescribing. There's really a particular opportunity to improve this. Both psychiatric prescribing in substance use-focused providers, as well as prescribing capacity for substance use in mental health clinics, so both directions. And workforce development, we really see the need to increase both the number and the training of behavioral health clinicians who accept insurance and are available to serve populations with co-occurring disorders. we think to address some of the lack of prescribing clinicians, students becoming physician assistants, advanced practice nurses, or physicians focused on behavioral health or primary care, should be required to pursue training and waivers to prescribe buprenorphine. And primary care and behavioral health employers in turn could consider requiring such credentials as a condition of hiring. Efforts underway now. The state has been partnering with medical schools in Massachusetts and the Mass Medical Society to develop some medical education core competencies on prevention and management of prescription drug misuse. Additionally, the state should continue to protect loan forgiveness resources and programs for providers who enter the workforce, specifically to care for co-occurring disorders. On payment policy, we have heard in the surveys frustration with low reimbursement rates for behavioral health, as well as with the fragmentation perpetuated by carve-out structures. So we think adequate reimbursement rates, consistent payment policies, so ensuring that all payers allow providers to bill for same-day mental health and substance use disorder services, and that providers know that that's doable, could reduce the financial barriers for providers who face that offer of integrated mental health and substance use disorder care. And the last point is that the ACOs and alternative payment arrangements really do offer opportunities to support the integration of behavioral health into medical care, so the health system can better address the whole person needs of this population.
So, open to any questions you may have on that. We did circulate it earlier and expect to make it public as soon as this meeting's over.
I know we're running late, but a great report. I think it highlights the problems around both access, quality, and ultimately the cost of behavioral health care. I think the point about medication-assisted treatment can't be reinforced enough. That's a really low level of substance use providers who are not providing what is now recognized as evidence-based. There was recently, I think, a brief in Health Affairs that said nationally, I think only 6% actually provide all three medications, which is also very low. So obviously something we need to do, and I think these are issues that I know the Baker administration and Mary Lou and Lauren have been focused on. So I think there's opportunity for great strides here. So good work.
Thank you.
David, just two other thoughts. One is that the research is really telling us that if we can treat people, we can start them on the medications in the emergency room, and get them immediately then plugged into ongoing care and ongoing access to that medication, it makes a huge difference. Getting emergency departments, especially in critical access locations, able and qualified to do that work is critical. The second point is that we have to hit a critical mass and we have to target it, because if only one provider in a primary care practice is asked to go for that license, they tend to resist. And the issue is these patients are extraordinarily complex and challenging. They gobble up time in a practice, and if only one or two clinicians are certified to do the work, that burden falls to them. And so thinking about a strategy that encourages a critical mass of prescribing clinicians and practices to come together to do that work makes it easier for that practice to absorb that work. So just a couple of key things, very practical things to think about.
Thank you, and certainly the grants that we have at the 9 hospitals on the first point, I think will provide a great platform for us, not only to think about that in-hospital initiation, but also what happens back in the community and what are the services that are being offered to those providers. And I would say, even at our site visit with Holyoke Health Center, they have a robust buprenorphine clinic that they are at capacity. And so, again, thinking about, and they are exploring ways to try to get more prescribers on, to try to be able to treat more patients, but they they are facing some serious capacity issues, just as an example on that. So thank you for those comments.
Last point, David, as you know, a lot of continuing medical education and continuing ancillary provider education represents an opportunity too. So, you know, a certain number of hours of my 100 hours of CME are mandated risk CME, and it seems to me this is a big enough problem that you could slip an hour in there and get to Barbara's point.
Any other questions or comments? David, I think we managed to come to a lot of good substance, say within time, pretty much. So our next scheduled meeting is in July, is that Thursday?
That's correct.